Welcome, everyone. My name is E. David Crawford, and on behalf of Verity Pharmaceuticals and Grand Rounds in Urology, I welcome you to our continuing programs on androgen deprivation therapy. Joining me today for the discussion are two internationally renowned leaders in the arena of advanced prostate cancer, Doctors Tia Higano and Evan R. Goldfischer. Dr. Higano, a colleague and friend that I have had the opportunity to work with for many years, and formerly professor in the Department of Medicine and Urology at the University of Washington, and is now an adjunct professor in the Department of Urological Sciences at the University of British Columbia. Dr. Goldfischer is director of Urology Research Division, a premier medical group, and also a clinical assistant professor of urology at the New York Medical College. Let's go ahead and get started. There are a plethora of side effects from androgen deprivation therapy as listed on this slide, and this is probably not all of them. Things from hot flashes, erectile dysfunction, diabetes, anemia, neurocognitive, testicular atrophy, decreased libido. But the one that we're going to highlight today, and one that's a major one because of the morbidity, relates to cardiovascular diseases. All right, how common is it? This is part of the problem right now. We know that there is a relationship between androgen deprivation therapy and the presence of cardiovascular events and MACE events, which we'll talk about. This is a nice review from Keating over 10 years ago, looking at the risk of diabetes, coronary artery disease, MI, sudden death, and stroke on men on various forms of ADT. It's a very telling table here in that we see that compared to no ADT here, that there is an increase in most of these areas: diabetes, cardiovascular disease, MI, and death and stroke with the use of ADT compared to no ADT. Of interest is bilateral orchiectomy. We used to think for years this was the most immediate, safest way to give ADT, when in fact some of the highest rates of cardiovascular disease is associated with bilateral orchiectomy. We think that the reason that is may be related to FSH and some other factors, but again, that's something that needs to be further investigated. So I want to give an overview of a presentation we have at the European Association of Urology meeting in Amsterdam this year. And I want to recognize my colleagues that were on this and worked on this with me on this slide. The background is that prostate cancer patients are often treated in the advanced stages with injectable androgen deprivation therapy. The association between ADT and increased cardiovascular events in patients is controversial. Most recently, very good publication in New England Journal of Medicine by Neil Shore, looking at a randomized phase 3 trial called the HERO trial, and the incidence of MACE was 2.9% in the treatment population and 6.2% in the control population with an LHRH agonist compared to the agonist relugolix that was used. However, other studies, including a meta-analysis from over 10 years ago, showed that there did not appear to be a significant difference in cardiovascular events on various forms of ADT. So it's not known whether cardiovascular disease is a risk factor for ADT, or ADT causes cardiovascular disease, or both. And we're going to discuss this in a few minutes. One potential risk factor for ADT is a prior history of cardiovascular events. And I'll show you there in a minute that this is a significant risk factor for the presence of a MACE event. So what do we have? We have a unique table I'm showing you here from a large data group that is called the Decision Resources Group, which looked at about 10 years, basically. We're going to focus on ADT in a group of 43,320 men. That's a pretty good group of people. You can see the average age here. This is a history of MACE, no history of MACE going into the study. Very nice representation from African Americans, about 13%, which is that of the general population. You had a personal history of MACE going into it at about 3%. Those that had a history of MACE were a little bit older, 76 versus 73%, but it was pretty much the same across various races as seen in this slide. Here's the first take-home message. Over a 12-month period of following these 43,000 men, and we look at event-free probability, what we see is the blue line here, no history of MACE right here, a very small difference, not 6 or 7% or 10%. However, if you had a prior history of MACE, which is sort of the gray-black line, we see here that it does approach that level of 8 to 10% over a period of a year. Now, if we look at 4 years, and look at the history of MACE, what we see, as we know, men get older, they have higher risk of that. And in this population, we also saw that. But again, there was a delta here, a significant difference between with and without cardiovascular disease. So what are our conclusions? MACE risk following ADT was higher for patients with MACE history. Okay, so if we use personalized medicine and focus, we're going to focus on those and really dig in and work with those that have a history of MACE. These findings are consistent with some previous publications looking at the elevated risk of cardiovascular events in men on ADT. And we have 10 years, 44,000 men. So I think this reflects what happens in the real world. Now, we're going to make adjustments and look at multivariate analysis. These are planned. We're going to be looking at other comorbidities, different forms of MACE, and things like that as we go through this. There remains a lot of unanswered questions regarding the various forms of androgen deprivation therapy and cardiovascular events. Unfortunately, there is a dearth of randomized clinical trials. Dr. Higano will begin the discussion by talking about a clinical trial called the PRONOUNCE study and what we know so far about that study. Tia, great to have you and look forward to your presentation now.
Thank you for that introduction, Dave. Yeah, we have been friends for a long time. So I thought this was a good opportunity to actually present the results of the phase 3 trial called PRONOUNCE that was actually presented at the European cardiology meetings in August of 21. And I've selected some slides from that presentation. I'm not going to go into it in as much detail as was done during the presentation, but I thought I would highlight some of the details so that there's better understanding of this trial. I don't think I have to mention too much about prostate cancer to this audience, except for that I want to emphasize bullet number 2, that atherosclerotic cardiovascular disease is the #1 cause of non-cancer death in prostate cancer patients. And we certainly know what the important role that ADT plays in treating various stages of prostate cancer patients. And you know, in their lifetime, probably half or more of the patients get exposed to ADT for therapy. So we know all the ways we can achieve ADT. We don't need to go into that in great detail. But we also know from prior observational and cohort studies that there do seem to be higher rates of cardiovascular events in men treated with ADT, and it may be related to destabilization of plaque. And you know, the most commonly used ADT agents are GnRH agonists. But we also know from observational studies that GnRH antagonists have been linked with fewer cardiovascular events compared to agonists. So the aim of the PRONOUNCE study was to prospectively compare the results of GnRH antagonist degarelix with a GnRH agonist Lupron on adjudicated cardiovascular events after 1 year of therapy in prostate cancer patients who came into the study with established cardiovascular disease. So as Dave mentioned in his study, these were the high-risk patients to have cardiovascular events. This is the schema. Basically, it's fairly simple. Patients were randomized 1-to-1. It was open label, either degarelix or leuprolide. They were treated for 1 year and followed for events. So the primary endpoint in the study is not a cancer endpoint, but a cardiovascular endpoint, which was the time to the first occurrence of a MACE. And the important thing is major adverse cardiac event. The important thing about these events is that these events were centrally adjudicated by uninvolved people. And again, the MACE included death, myocardial infarction, or stroke throughout the 12-month treatment period. There were a variety of sensitivity analyses that I won't belabor, but I do want to point out how the statistics were organized for this trial. It was really based on the Albertson study that was published in 2014, putting together 6 phase 3 trials that were randomized between an antagonist degarelix and an agonist leuprolide. The total study included 2,300 men that were treated between, and this is important to remember as I go forward, 2005 and 2013. And what they found when they pooled all this phase 3 data together from 6 trials was that there were 5.1% cardiac events in the degarelix arm versus 10.2% in the leuprolide arm. So that should have, if you use these figures, the trial should have accrued over 800 patients. So this just shows, this was a global trial, and this shows what actually, the number of patients who were accrued. It was 545, not the over 800 that was projected. 276 in degarelix and 269 in Lupron. The reason that we didn't accrue the planned number of patients had to do with an interim analysis, and I'll talk about that in a second. But the baseline characteristics between these two groups were quite similar. I think it's important to note the cardiac drugs that these patients were on. They're fairly well balanced here at the bottom of 3 different categories: lipid lowering drug, RAS inhibitors, and beta blockers. So there was not any indication of significant imbalance there. But what we saw was that in the leuprolide arm, and again, this is the primary outcome. This is where the gold is. In the leuprolide arm, there were only 11 events in all of these, 200 and something patients in that arm, whereas in the degarelix arm, there were 15 events. So that the numbers turned out to be 5.5% in the degarelix arm for MACE events versus 4.1 in the leuprolide arm. And again, I just highlight this to show what was expected based on the stats. The degarelix arm performed as predicted, whereas the leuprolide arm did not perform as predicted. It was significantly lower than what was expected. So when we look at the HERO trial and many of the other phase 3 trials that have reported differences between agonists and antagonists, they're not using these adjudicated cardiovascular events. They're using adverse events. And it's interesting when you look at PRONOUNCE, the differences from adverse events In the degarelix arm versus the leuprolide arm, there still appears to be more in the leuprolide arm compared to the degarelix arm, which of course was what was expected. And, you know, you have to ask yourself, if an event happens on the leuprolide arm, it might, the investigator or the coordinator might be more likely to say this is attributed to the leuprolide arm because it's the agonist, and, you know, already sort of have some bias in there perhaps. At any rate, the PRONOUNCE trial was the first dedicated global trial that actually looked at adjudicated cardiovascular outcomes. It was terminated as far as accrual prematurely because of the smaller number of planned events. There was essentially no difference in the rate of cardiovascular events at 12 months between the patients treated with agonists versus antagonists. So at this point, this trial did not show any improvement in cardiovascular safety when patients treated with the antagonist compared with the agonist. Now, I think there are some important things from the clinical perspective that we should take into account. One is that many of the agents we're now using for prostate cancer that have extended patients' lives, they also have potential significant cardiovascular toxicity, especially in patients with prior cardiovascular disease. So I think it is important to do a baseline cardiovascular risk assessment before initiating any of these drugs. And there's also a need for rigorously conducted cardio-oncology trials going forward to better define the cardiovascular risk with all of these new cancer agents we're using in prostate cancer patients. So one of the things about the PRONOUNCE trial that I alluded to earlier that I just want to highlight, and Dave and I might want to talk about this afterwards, but all of the patients in this trial were mandated by the trial to be under the care of a cardiologist. And I mentioned the statin use. I pointed that out, and the patient characteristics was quite high. But if you actually go back and look at what kind of treatments the patients were on when the Albertson data was compiled, you know, there's been a dramatic change in the use of statins over these years that could have had an impact. So, you know, I think that the take-home message for me from the PRONOUNCE trial is that in this day and age, there doesn't seem to be a huge difference in patients who are at high risk, meaning prior cardiovascular disease for these events due to ADT of any kind. But it's important for us to assess the patient before starting these drugs to figure out if they are in the high risk group, and then make sure they're connected with the cardiologist. And I think that this message is a message we should give, not that necessarily one drug is better or worse than the other.
Yeah, thank you. Great presentation. Disappointing results to have a study that's negative in a way, but you and I remember our years in SWOG is that before we started a study, we met with biostatisticians and we gave them sort of what we thought the delta would be. And that's how they would power the study. And they were given the wrong information. And we both of us remember the Albertson data and other data that came out with degarelix too. With reduced cardiovascular. And so I don't think that was a mistake to say what was said, but I think what you pointed out very nicely, some things that would explain it and were missed. And that was better, and there was a lesson here too about better cardiology intervention and following and judicious use of statins and other things like that we know about. You know, there was an analysis that was published in Prostate Cancer and Prostate Diseases by Neil Flesher, Wallace, and a couple of other folks. They called it the mispronounced trial. And they did some statistical maneuvering that basically looked at whether it would the number of patients that it would take to show a statistically significant difference. I don't know if that means a clinically significant difference, but it was way north of 2,000 patients and closer to 2,500, if I remember correctly. So where are we going with this? What are your thoughts?
Well, first of all, I will say that I think that's the exact same exercise that the statisticians went through for the study, which is why they stopped it earlier, because they realized that even if we treated the projected number of patients we needed, we would not hit any meaningful endpoint. So I think where we need to go going forward is really just keep in mind this data as clinicians and be a little bit more sensitive to our high-risk patients and making sure that they're connected with the cardiologist. Now, I will say that I'm very impressed at how cardio-oncology is really booming as a field. And I think, especially for those of us in medical oncology, across the board for any kind of cancers, there's quite a few drugs out there that cause cardiac toxicity. And so I think we just have to forge good working relationships with our, whichever cardiologists are in your area, and get some help with some of these things when we have these patients that need attention.
Particularly the men that based on what I just showed too, points out that the folks really, the men really at risk are the ones that have prior cardiovascular disease and risk factors, hypertension, smoking, obesity, all those things like that. Not a surprise, but I think that plus what was this analysis of mispronounced and what happened, so to speak, puts that into light and perspective.
Right.
And
I think
great presentation.
Yeah. Let me just make one more comment if we have time. I mean, I think the other thing that as clinicians we can do is try to help our patients understand what they can do to mitigate some of the other effects of ADT that you so nicely showed. I mean, for example, diabetes and cardiovascular disease just go hand in hand. And so if somebody has that tendency, I mean, getting into the exercise routine, appropriate diet, et cetera. I mean, those are things, it doesn't take too long to mention it, but it's a lot harder to enact it as a patient, I think. But I think if we don't mention it, it's kind of like smoking. If you don't suggest your patient stop smoking, they might not consider that an important thing. So I think those are things we can do.
I have a lot of men on ADT just like you, and they're a group of men who keep their weight down, who work out, who keep their muscle mass up. And you know what? It hardly touches them except for hot flashes. And I think that's one of the things we got to say. But if you got risk factors, and that's what that's out there, we got to work harder on them. All right, thank you, Tia. Let's move on to Dr. Goldfischer. Evan will be focusing on managing cardiovascular risk in the real world, including patient selection, compliance, and recommendations. He and his colleagues have been leaders in the field with their advanced prostate cancer clinics, setting up pathways to improve patient outcomes in their practices and throughout LUGPAs in the United States. Evan, thanks, and look forward to hearing your presentation.
So I'd like to present several slides that backs up some of my positions that I've already talked about. The first is the role of androgen deprivation therapy in cardiovascular disease, a longitudinal prostate cancer study. And this is Daryl Leong and Dr. Pinta's study from Canada. And I know you've seen some of the data already today, but the conclusions are that 2/3 of men with prostate cancer are at high cardiovascular risk. There is a positive association between a plan to use androgen deprivation therapy and baseline cardiovascular risk factors. However, this association is explained by confounding factors. Again, what they're trying to elucidate here is that men with prostate cancer have some of these high-risk diseases that we've talked about, such as diabetes, hypertension, dyslipidemia, and as a result of these diseases, they're at higher cardiovascular risk. Adding androgen deprivation therapy can further increase the risk, but androgen deprivation therapy in and of itself may not be the cause of cardiovascular events in the average baseline population. So some other key quotes from the study: there was a positive relationship between each major cardiovascular risk factor and the use of androgen deprivation therapy. However, after adjustment for age, education, alcohol use, body mass index, and time from prostate cancer diagnosis to eligibility assessment, these associations were significantly attenuated. This suggests that the higher rate of cardiovascular disease risk factors among those in whom androgen deprivation therapy use is planned or implemented is driven by their older age and lower education. The increase in cardiovascular disease risk associated with androgen deprivation therapy use may be accounted for by differences in baseline confounding factors. And the positive relationship others have observed between ADT use and cardiovascular disease might be explained by unmeasured cardiovascular disease risk factors. We hypothesize that part of the association between ADT use and cardiovascular events that has previously been reported may be driven by these previously unmeasured confounding factors. Again, identify these high-risk patients with cardiovascular disease or potential cardiovascular disease and manage them during their androgen deprivation therapy aggressively, either with their primary care doctor, their cardiologist, or if you have one in your community, a cardio-oncologist. Now we'll talk a little bit about the PRONOUNCE study. In this international multi-center prospective randomized open label trial with blinded endpoint adjudication in patients with prostate cancer and pre-existing ASCVD, no difference was observed in the rate of cardiovascular events with the GRNH antagonist dagarelix compared with the GnRH agonist leuprolide. However, accrual to the trial was stopped early, and there were fewer than the planned participants and a number of major cardiovascular events, resulting in wide confidence intervals and low statistical power, and therefore the relative cardiovascular safety of GnRH antagonists and agonists remains unresolved. As expected, testosterone levels, rates of progressive disease, and urinary symptoms were similar between the two agents. So essentially, to do a major study to really assess the effects of cardiovascular disease using antagonists or agonists is going to require thousands of patients. So the PRONOUNCE study attempted to determine a lower CV morbidity from GnRH antagonists than agonists, but the data would suggest that instead it has shown that clinically meaningful differences are unlikely to ever be demonstrated given the relatively low absolute event rates. This may then be the final word on the topic. We're talking about managing prostate cancer patients for longer survival and quality of life. Patient management and adverse events with agonist versus agonist does not appear to make a huge difference. Cardiovascular risk, hypertension, bone loss, cholesterol, glucose, weight gain, these are really the risk factors that you want to be managing. And Dr. Klotz has elucidated in a separate paper a nice ABCDE approach. Again, team management with urology, oncology, in an advanced prostate cancer clinic, and letting the primary care doctor or cardiologist know what's going on is the best way to manage these patients. Encourage cardiovascular exercise. For those who are diabetic or morbidly obese, try and get a dietitian or nutritionist involved. Depending on your EMR and what you're able to elucidate from it, you may need a pharmacologist or a PharmD or a tech to make sure there are no drug-drug interactions. And then you've got to monitor patients with compliance, especially with the oral agents. It's one thing to give an injection to a patient in the office, you know they've gotten it, but you've got to also manage their oral therapy and look at their refills. If you've got in-office dispensing, you can tell by how often they're refilling their prescriptions if they're actually taking their medications. And finally, all these drugs are very expensive. Until we get some more generics in the realm, understand what your patients can afford, what they can't afford, try and manage their wallet judiciously, and when possible, look for external sources or apply to any sort of program drug companies have to try and offset some of these high costs.
Great discussion. Now, as you and I have discussed many times, and you mentioned the LUGPA organizations, and particularly yours, have developed very specific clinics for advanced prostate cancer, which I believe has had a major impact on side effects and outcomes. What can we do to improve education and the implementation of these findings? We in Grand Rounds in Urology focus on education. We have a lot of different talks and things like that. But what is there anything missing? Any ideas that you have how we can get the word out to manage some of these side effects and deal with it in your clinic?
So in LUGPA, a lot of practices have established advanced prostate cancer clinics. I think prostate cancer is a urologic disease, and it's not just a question of doing the surgery. I think we can administer the androgen deprivation therapy, perform the required imaging, and advance care to more novel therapies as necessary. But I think what has happened over the last 10 years is advanced prostate cancer has really become a specialty within itself. Just like you want someone taking out your prostate and doing robotic prostatectomy who does it on a regular basis, because there's so many drugs, because there's so many guidelines, NCCN certainly changes on a regular basis with regard to what medicine should be administered, genetic testing, and imaging. I think there needs to be someone or someones in each practice that really specializes in advanced prostate cancer, that has APPs available to them to help manage these patients. And really, it's become a subspecialty within prostate cancer.
So Evan, you outlined a number of the issues with things where we should try to intervene in cardiovascular and so forth and so on. And we all know that a lot of things are bad for us. But the real question, I see a lot of these men, and they're overweight, they have diabetes, they have hypertension, they don't exercise, they don't eat right, they don't. I mean, to me, one of the major things is motivation. We all know smoking's bad, but people still smoke. We know other things are bad. How in the heck do you motivate some of these men to change their lifestyle to accommodate ADT and not be at risk of this stuff?
Wow, that's a big question. I wish I had the magic bullet for that, Dave, but I think this is where chronic care management comes in. I think it's dramatically underutilized in urology in both the private practice and academic settings. You need to touch base with these patients on a regular basis. It can't just be every 3 months you go in and spend 10, 20 minutes with a patient and hope that they're going to change their lifestyle. This is where the use of APPs really comes into play. And with chronic care management, touching base with them several times a month to make sure they're taking their pills, to making sure they've got their imaging appointments scheduled, asking them about their blood pressure, their diet, how much exercise they've done. You really need a coach, a cheerleader, almost like a personal trainer, but this time with prostate cancer, encouraging diet, exercise, and adherence to the regimen.
So I know in the UK, they use refer most of these patients to cardiologists. So they have cardio oncology almost as mandatory. Are we at that point in the US where men have hypertension, other risk factors that they ought to be seeing a cardiologist? Or what do you do in your advanced prostate cancer clinics? What do you do in LUGPAs and so forth?
So it really depends on where you are and what facilities and what resources you have. If you're located in a major city, sure, you probably have access to a cardio-oncologist, and certainly if you're at a major medical center. But what happens if you're in a more suburban or rural setting? odds are you're not going to really have a cardio-oncologist. If you do, there might be one for the entire department. And you may not even have enough cardiologists. There's certainly a huge manpower shortage now in medicine to manage all these patients. So I think it's really identifying the patients that are at risk and referring them to the cardiologist or cardio-oncologist if you actually have one. But most of the time, it's going to be working with the primary care doctors.
I know it's easy to shout that out, but you're right. Try to get an appointment with the cardiologist. You're looking at months and months wait, at least in around where I am right now. What should the practicing urologist try to do to ameliorate some of the side effects of ADT, particularly the cardiovascular events?
That's a great question, Dave. How should urologists, especially in private practice, ameliorate the side effects of ADT, particularly with cardiovascular events? I think the answer here is to identify the appropriate patients. We know that the incidence of cardiovascular events in the healthy population, so to speak, is low. It's much higher in patients who've had previous cardiovascular events or have significant risk factors. So we're administering androgen deprivation therapy to a lot of older men who have hypertension, dyslipidemia, and diabetes. These are the patients that you've got to identify, and these are the patients you really want to co-manage with your primary care doctor who's taking care of the patient or with their cardiologist. You want to certainly encourage weight-bearing exercises. You want to encourage cardiovascular activity. You want to encourage a healthy Mediterranean diet, and certainly want to keep their diabetes under control, the hemoglobin A1C, as well as much below 7 as you possibly can. So again, I think identification of these patients is extremely important, and then communication with the primary care doctor and or cardiologist is also key.
Any further comments you have, or can you just sum up what you have said and what the take-home messages are for our audience?
I think it's very important that advanced prostate cancer be considered its own subspecialty. These patients are managed in an advanced prostate cancer clinic with support of APPs, and that it's important to have frequent touch points with these patients to keep them compliant with their medications, with their laboratory testing, and with their imaging in order to try and provide the best quality and quantity of life possible.
Let me ask Evan and you this question, Tia. We'll start with you. The goal of ADT is to lower testosterone, I believe, and the lower the better. And most of the new drugs that work squeeze a little bit more out of T and the tumor and deprive it. How are we going to do a better job of administering these drugs on time and also monitoring T?
Well, the monitoring T is easy. You just order it, right? I mean, I
order PSAs, not T levels.
Well, I know, but so quite a number of years ago, I don't want to say how many, I just started ordering testosterone with a PSA. To me, it was a paired order, and it doesn't take that much, especially if you make it part of your clinical pathway. And everybody knows that's what's supposed to be ordered for that patient at that given point in time. So I think that part is easy. It's the keeping them on time. And you and I have had, a lot of experience looking at the impact of erroneous administration of hormone therapy and the impact it can have. So again, I do think it's a workflow situation where, if you're seeing the patient today and your office knows they're on continuous ADT, let's say, they just have to prospectively order those to keep on time. And if the patient is not on time, usually there's an alert in the EMR saying the patient didn't show up for that appointment. And that's where your nurse navigators or nurses come in, because they should be the ones saying, hey, Dr. Crawford, your patient didn't show up on time. And then they should be the ones going to nag that person to come in for their shot, whatever kind of shot it is. And And I do think, clearly it's easier for shots that are not every month. The longer the shot you can give, maybe the better off for a lot of people, especially now that we still have COVID, I should say.
We sort of looked at that with COVID
Mhm.
too, with the longer injections. All right. Well, thanks very much for your time. And Dr. Goldfischer, any parting remarks?
It should be automatic that almost every time you order a PSA, especially these advanced patients, you're checking a testosterone, but that doesn't really happen. What is nice, though, is there are a lot of programs now, analytic programs that can go into your EMR, have algorithms preset for each patient and actually prompt you at each visit to make sure you're ordering the right labs, the right tests, monitoring testosterone and whatever the safety labs are necessary, and performing the correct imaging studies on time. These are very inexpensive compared to the benefit that they give. There are a lot of new programs out there. There's a lot more competition in this field. And I would encourage anybody who doesn't have the ability to set these algorithms up themselves, don't trust yourself to remember each time. All these patients are complicated. And it's nice to have prompts on your EMR screen to remind you what to test for.
Thank you. I want to take this time to thank both of you for taking your time to share your thoughts with us. I want to thank Verity Pharmaceuticals and Grand Rounds in Urology for making this happen. And we look further in the future to other educational events that we, Verity, and others will be doing. Thank you.